Hello and welcome to our online training for mental health safety planning. We've had a lot of success with the launch and initial face-to-face training sessions that we delivered at the end of February and early March in 2020, and we've decided to record the training and put it on our website so that people can access it and use it to help them support individuals with creating mental health safety plans. I will cover as much as I can in this recording, but if you have any questions, please do contact me. My email address will be on the final slide for follow-up. So I'd like to start with just a welcome to everyone. My name is Hannah Clark. I work in public health at Cornwall Council in the suicide prevention and mental health team. My colleague Paula Chappell is a public health practitioner in the same team, and we've been working together for a few months now to develop the safety plans and launch the training to everyone. She won't be on the recording today, but we've worked together to make sure all of the necessary content is in the slides that are going to follow. I just want to also add a disclaimer here that we will be talking about some sensitive material in the next hour or so around suicide, self-harm and mental health. So please do seek support if you feel uncomfortable or need support because of any of the content I talk about. There are some phone numbers here for helplines that are available for you to listen to if you need it. So what are we going to do today? I'm going to start by talking about safety planning, what it is, how to use safety plans, and also when not to use them. I'll also talk about what to do in a crisis if safety planning isn't relevant. I know some of you already have safeguarding procedures in place to support you with this, but it's still important that we discuss what we do in various circumstances in case you don't have these procedures in place. We'll also then have some time to practice. In face-to-face sessions, we had a lot of feedback about how useful practicing with some case studies was. Obviously, you're welcome to do this alone with the video, or if you can get a group together, either in person or over Skype, to chat through different scenarios, you're more than welcome to do so. Before we start, we've also had some feedback that it's really useful to have a safety plan in front of you while we talk through them. So if you click through the hyperlink to our website and download and print one, or keep the interactive version on your screen, that would be really helpful. The link is this PDF one here. Okay, so let's get started. So it's quite useful to start out by giving some context around suicide in Cornwall. I've included some statistics here. So for comparison, around 765 people are murdered in the UK every year. Around 2,000 people are killed on UK roads every year, and 6,000 people die by suicide. So that's 1,500 women and 4,500 men. So we know that these numbers are significantly higher in Cornwall and the Isles of Scilly, and we have an ongoing agenda and additional funding in public health to support suicide prevention initiatives. We have quite a few projects ongoing at the moment. This is really where the drive for mental health safety plans has originated. Additionally, we know some key information about people who do choose to take their own lives. Within the last 12 months before they die, we know that a third of people who suicide in Cornwall have had contact with a specialist mental health services, and a third have had contact with their GP about either a physical health complaint or their mental health. And we know most importantly that a third of people who end their life have no contact with any services at all. So this is another reason why we're trying to roll out mental health safety plans as a community-centred tool, because of even those who contact their primary healthcare service might not mention anything about feeling suicidal, and so therefore more than a third of people who might want to speak to someone about their mental health are either uncomfortable talking to health professionals or unable to. So we're hoping that mental health safety plans can be a key to having wider conversations about mental health without any stigma throughout the community. So what are mental health safety plans? A safety plan is a tool to support someone with their mental health, and they're designed to be used by people experiencing intense suicidal thoughts to guide them through their feelings of crisis. However, as I'll reiterate a lot in the next hour or so, they are not exclusively for individuals who are experiencing thoughts of suicide. The research we have has demonstrated that they're one of the best tools to alleviate future suicidal behaviour. Safety plans are assets-based, so they focus on an individual's strengths and unique abilities to support themselves in times of low mental health or mental health crisis. If you're interested in reading the research we have, I've linked to the article here. The research is by Dr. Barbara Stanley and Gregory Brown. In this particular case, they also conducted follow-up phone calls, which did prove to be beneficial, but it's the best evidence we have for the use of safety planning so far. There's also a lot of useful guidance about safety plans on the link below that, www.suicideinfo.ca. An example Dr. Barbara Stanley uses in her work is she compares a mental health safety plan to a plaster cast. For example, if someone broke their arm, you wouldn't expect them to wait 6 to 12 weeks to be seen by a doctor to set the bone. They would put the cast on the arm and then and there to help and heal it in the short term, and then maybe combine this with physio or other treatments at a later date. So similarly with mental health, safety plans serve as a way to support individuals who are in crisis right then and there so that they have something to help them through their difficult feelings as soon as possible and don't have to wait for help. Another example we like to use is to think of safety plans as a seatbelt. So you put it on before you start your journey and you keep it on for when you need it. And it serves as this preventative tool to support people to stop them from reaching crisis in the first place. I just wanted to include here some BBC coverage for safety plans for two reasons. So firstly, to demonstrate that they're quite popular across the country at the moment, but also to highlight what Simon says here about his experience of making and using a safety plan after self-harming. He says that actually when he found his safety plan to be quite generic with little or no relevance to him, and that it was pretty pointless. So this sounds quite damning, but actually he then follows it up by saying that for him the essence of a safety plan is that it's unique to the person and it's tailored to their experience and their strengths. This has also been reiterated in a lot of our focus group feedback as well. So I'll come back to this a lot in the session about how important it is to tailor plans to the individual who is going to use them so that they don't become just a generic tick box exercise. So how to and when to use a safety plan. Who needs a safety plan? Well, while safety plans were originally intended for people struggling with suicidal thoughts, we believe that safety plans can be used and be useful in supporting anyone with their mental well-being. They can be really helpful if you have experienced feelings of anxiety, you have experienced feelings of low mood, you use or have used self-harm as a behaviour to help you cope with feelings, or you have had thoughts of suicide. We really want to emphasise here that everyone has mental health and everyone sometimes has poor mental health, and safety plans can support anyone within this spectrum of feelings. So who can help make a safety plan with an individual? We have here a family member, a friend, or a professional. So we've listed all of the above because really anyone in a trusting relationship with an individual can support them to make a safety plan. What I've said before about the plan being individual to the person is really what's key here. If you have a trusting relationship with someone, you're more likely to open up and have an honest conversation about your mental health with them. It's okay if this isn't you as a professional. If the person you're supporting feels more comfortable having that conversation with someone else, it's more than okay to give them guidance and support around how to fill out the safety plan and use it and allow them to have that conversation with someone else. As I said earlier, the real magic of the safety plan is in its creation, so it's essential that this is done with someone who the individual trusts and feels comfortable with. So, as you'll see in front of you, the safety plan is designed as a stepped approach, and the theory behind it is that you work through it as this stepped approach until you feel safe again. Obviously, we understand that mental health often doesn't develop in such a way. It can jump from 0 to 100 very quickly, and sometimes you might open up your safety plan and be okay with steps 1 and 2, and sometimes you might need to jump straight in at 4 or 5. And that's absolutely okay. The other important thing to remember with safety plans is that they are living documents, so they will change as you use them, and it's important to update them. So if, for example, you called Margaret last time and she wasn't very helpful, just take her off and add someone else in. Or if you did something that really helped that you hadn't thought of, add that in afterwards. It's absolutely okay that they change as they go. So what does each step of the safety plan actually mean? I'm going to go through and discuss them now, and for the first few I'll ask you to pause the video and have a brainstorm, either by yourself or with others, to come up with some ideas of what you or someone you're supporting might put in each step. This can be helpful just to have a list of ideas to offer if people are struggling to come up with suggestions themselves at first. So the first step is warning signs. What feelings or actions or thoughts that you let you know that you're not feeling mentally well or you're on your way to thinking about suicide. So pause the video and have a little brainstorm, and we'll come back together in a minute and I'll read out some suggestions that we've had. Hi, welcome back. I hope you've had a good brainstorm. So some examples we'd come up with here were an argument with a loved one, not getting enough sleep or getting too much sleep, dropping your usual activities, self-isolating, or having an irregular eating schedule. And what we noticed in almost all of these and the feedback we got from our face-to-face sessions is that what it really is a change in behaviour. So for example, if you usually sleep really well, then not sleeping would be a good warning sign for you. But if you normally don't sleep well and suddenly you're tired all of the time, then that would be a change in behaviour as well. So, and the same goes for self-isolating. I know a lot of people who are absolutely fine in their own company, but if suddenly they're not, or a social person starts to cancel all of their events, then these would be examples of changes of behaviour we might notice in them. And I'm sure you all came up with a lot more, but as I said earlier, it's really good to just keep this as a list of suggestions up your sleeve in case the person you're working with can't immediately bring things to mind. So step 2 is coping strategies. These are things you can do to lift your mood and take your thoughts away from patterns of scary thoughts or suicide. And this step doesn't include bringing anyone else in yet to help, it is just to support yourself. So pause me again and have a brainstorm and come back when you're ready for the next slide. Okay, welcome back again. I hope you had another good chat or brainstorm alone, and here are some examples that we came up for this step. So a distracting activity, physical activity, meditation, breathing exercises, or watching your favourite TV show or a film. And again, it's really important to personalise these steps. I know physical activity and meditation work really well for some, but I also know some people want absolutely nothing to do with it. And that's important that you really ask what they're likely to stick to and want to do, to have lots of ideas up your sleeve if none of them are really working. So step 3 involves other people getting involved to distract you or to go out and about to distract yourself. Now, I know for a lot of people leaving the house is not a possibility for various reasons, so this step might need to be tailored for specific situations, but some examples that we had thought of were to call a close friend or family member or meet up with them where possible, to go for a walk, to go online and watch webcam footage of zoos or of museums, to watch your favourite YouTube comedian, to play a game online or on your phone, to read a book or do some crafts, and if possible to go to a cafe or library just to be around people but not necessarily to talk to them. So this really needs to be tailored, and it's about how we can use other people or places to take our mind away from our thoughts. So step 4 is about people who can help, and this can be family and friends, service providers, or spiritual people. And this is about how you find someone who you want to speak with about how you're feeling. And so up until this point, the purpose was to distract and to take your thoughts away. And now the steps are about discussing how you're feeling with others. So step 5 is if you really don't feel that you're comfortable talking to friends and family about how you feel anymore, and you really need to speak to a professional instead. On the back of the PDFs and the Z cards, there's a list of number of agencies to speak with based on various demographics, and also various ways to talk to them, either over the phone or via text or web chat if that's preferable. It's also really useful to think about the agencies that might be appropriate for you and add in their contact details in step 5. Some examples here we've listed, but there obviously can be some numbers on the website or safety plans themselves. So the final step, step 6, is the one that's most important for people who are at risk of suicide or who use self-harm as a coping strategy. So up until this point, safety plans are really good for anyone with any level of low mood or ill mental health. But step 6 is really specifically about how to keep your environment safe. We know from research that the more steps you put between the thought of self-harm or suicide and the action itself, is more likely people are to remain safe. So in this sense, it's important to have a conversation with someone about whether they've thought about this before or even planned it. We've got some time later in the training to talk about how to ask about suicide, but again, this is why it's important that this conversation is had with someone who the person really trusts and can understandably be a really sensitive conversation. So some examples of how you might be able to keep the environment safe could be removing guns or rape from the home. It could also include taping a blade that you use to self-harm with a whole roll of sellotape to just slow down that time between thinking about self-harm and actually being able to do it. Similarly, if you speak to someone and they mention that they're hoarding medicine, have a chat about how you could safely remove that from their home. Some other things to include are here. So the box about reasons for living and life-sustaining things are really important, and I'll come back to this at one point later on, as it's one of the main reasons we say not to try and complete and make a safety plan at a point of crisis, because it's often really hard to find a reason to live or something that's life-sustaining if you're at that point, but it can be really powerful if you have it there when you need it. It's also really important to include phone numbers for everyone. At a point of crisis or panic, looking for numbers isn't exactly what you want to be worrying about, so it's really helpful to just have them all in one place. And finally, there is a box to fill in if you no longer feel safe. What will you do? So this means if you've gone through the whole plan and you no longer feel like you can keep yourself safe, you've called everyone, you've tried to distract yourself and you can't cope anymore, what is it that you're going to do? Is it that you'll check yourself into an A&E? Is it that you'll drive to your friends or your mum's house? What is it for you that's your final emergency measure? So hopefully that's all clear. Obviously, if you have any questions, please do get in touch. To move forwards now to talk about when it's not okay to use safety plans and what to do in terms of suicide prevention in a point of crisis. So when is it not okay to make a safety plan? It's not okay to try and make a safety plan if someone is in the middle of a crisis, if they're actively suicidal or psychotic, if they are under the influence of drugs or alcohol, or if they've already taken action on their suicidal thoughts. So why is this? They really shouldn't be written at a point of crisis for the reasons I listed earlier, because it's important that the person has a reason for hope and for living while writing it. It's also important to add that they can be made in more than one sitting. So if you start to write one and it's just not the right time, it's okay to leave it with someone and come back to discuss it later. Just make sure that in the meantime you've signposted them to where they can get support in crisis if they find themselves in that position before you get to complete the plan. So what should you do in a point of crisis? I know some of you will have already had training on this or will have your own safeguarding procedures in place, but in case you haven't or you need a refresher, we thought we'd just take some time now to talk through it. We've made a short flowchart here to work through, and I just thought I'd talk it through with you now. So to start, when you're talking with someone who's struggling, it's really important that you connect with them and you listen and you validate how you're feeling. When it feels like an appropriate time, you should ask clearly and directly about if they are having thoughts of suicide. And it's really important that at this point you reassure them that it's good they feel able to share with you how they feel and that you can take this time to build some hope for the future with them. It's also important that if they say no at this point, it's okay to ask again, and it's really important that you do so because sometimes people will say no initially. It's also essential that you then ask if they've already done something to harm themselves. Sometimes people have already taken action on their thoughts, and if they had, it's really important to then just put aside all sorts of safety planning and focus on keeping them safe, calling 999 if necessary, and that you take them to hospital. Even if they've had an overdose a few days before and they say they're fine, it's still in their system, and it's really important that they get seen by medical professionals. If no harm's occurred, then it's important to signpost to support agencies where possible. And if you feel confident that it's appropriate to begin creating a safety plan, then absolutely please do so. But again, if urgent rescue is needed, then safety planning is really not appropriate. But this is something that you could come back to at another time once the person is safe. So some things to think about here when you're having a conversation with someone around suicide, that is. Time is really essential that this isn't a rushed conversation. Privacy, make sure that you have space to speak privately if necessary. Body language, make sure you look attentive and interested in the conversation and just sit next to them and be there. Try to use appropriate eye contact. Obviously this depends on the person. This might be no eye contact or this might be more eye contact. You will obviously know the person you're working with best. Give them your full attention. This seems a bit superfluous to say, but it is really important. You're not on your phone and you're not busy doing another task. And And stay calm is essentially stay calm during this conversation. Many people have been in this position before, and having a calm, attentive conversation is important in building confidence and supporting individuals in the future. Just also be careful what you say. Make sure you don't dismiss how people are feeling. Try and avoid phrases such as surely things aren't that bad. And whatever you do say, it's really important that it is non-judgmental and there's no blame. It's important that you don't make them promise to not talk about it with anyone or be annoyed that they're telling you how you're feeling. We really want to reduce that stigma and because it stops people from being open about how they feel. So what should you say? You're all here and in your jobs because you care about people, so just be sure that you take this into each conversation and remain patient and kind and compassionate with everyone you interact with. I want to point out here as well just some stigmatizing language we're trying to avoid going forwards. For example, we are trying to encourage people to avoid the phrase committed suicide, as this harkens back to when it used to be a crime to take your own life, and it was a crime until 1961. It also implies committing a sin. So instead you can say somebody ended their life or took their life. You can also use the word suicide as a verb. It does sound a bit clunky, but you can say somebody suicided. We do recognise that this phrase has been used for a really long time and it is difficult to transition. We also avoid saying things like successful or completing a suicide anymore, obviously because this implies that it was something we are hoping people to achieve, and this does relate to the phrase failed attempt, which is similarly unhelpful in equating continuing to live as failing to achieve something. We're also moving away from the phrase deliberate self-harm, and this is used quite a lot in clinical settings, but it really passes a judgment about someone's intentions, so it's not very helpful to call it this. And finally, just the phrase suicide epidemic is understandably really unhelpful and just sensationalist. It doesn't help raise awareness, and it really just creates fear and stigma more around suicide. So we're hoping to try and avoid using all of these phrases in the future. And finally, as I mentioned earlier, it is really important you follow your own procedures in case of an emergency, and if it's necessary, just call emergency services. So I'll just show you now where to go for more online training and resources. On our webpage where you found this video, we have a directory of local resources here. Similarly, we have some useful training videos and documents if you need more support and guidance remotely. If you're able, also, Healthy Cornwall offers some suicide prevention and mental health first aid courses that run regularly. They also offer bespoke training for your organisation if this is appropriate. So, for example, early in the year, they delivered training to Man Down, which is a charity for men's mental health. And they did it on a weekend, and so they were all able to be trained. They also run assist training, which is applied suicide intervention skills training. It's a 2-day course, which is excellent. And there's also Safe Talk and Suicide Talk, which are more bespoke sessions for shorter amounts of time that can be organised for a workplace or community group. You can book all of these online or on the Healthy Cornwall email team, which both links are on the slide. So some practice. So I'll start to show you again how to access the plans, and then I'll walk through some case studies and give you the chance to practice. So here again is our webpage with the link to the PDF, and if you're interested in bulk ordering some Z cards, if you email the public health desk, we'll see how we can get some to you. We'll be able to send them through NHS Courier or local government offices Courier as best we can. Just let us know where you'd like to pick them up. And there again is the PDF, which hopefully you got earlier, and that's the email there. There are also some apps we like to signpost people to. They follow a really similar format to ours, but they include adages to link directly to phone numbers or to include pictures or songs, which can be a really nice addition. We've had feedback both ways, that some people love to have everything on their phone and some people hate to look at their phone when they're not feeling great. So we want to make sure that both options are available. And obviously you could instead of the app, you could just take a photo of your safety plan and keep it on your phone if it's too big to kind of open up in public. So really it's just about being creative about what works for you. So for some practice, I've got 3 case studies to discuss with you. If you pause on each one and discuss it either with a colleague or work through it on your own, and then play again, and I'll add my thoughts for each of you to consider. If you also want to practice working through a case study with someone and role playing each part, we've had feedback that that might be useful to do, just to kind of takes the stress out of the conversation, as if you know that would be a bit more tense if you were working with a client. So we absolutely encourage you to do that if you want or can. So here's the first case study. Pause the video now and then unpause when you're ready to discuss it. So for this one, we've said that it would be relevant to make a safety plan here. Again, though, it's about reading and knowing the person you're working with. And if they don't seem receptive to making one, or you feel they might do better with an alternative or additional support, that's absolutely up to you. But in terms of the safety of making a safety plan, it's absolutely appropriate to make one if that's what you want to do. Another one here, again, pause the video and then just start again when you're ready. So I'm sure all of you guessed here that safety plan's absolutely not appropriate. If at follow-up they seem more receptive, absolutely you have a wider conversation about it. But for the moment, their physical safety is the most important. So just ensure that he's linked into appropriate support and services available, as well as calling 999. So a final example here, same as last time, have a pause and let me know when you're ready. So we've said it would be useful here, but we've also noted that there should be a wider conversation just around her support network and managing with her able to kind of support her at school. So that might be something you talk about as well. But yeah, again, in terms of safety, absolutely fine to make a safety plan if that's what she wants to do. So finally, the key points I'd like to just draw from this training. Firstly, as you've seen with each of the case studies, it is really essential that we don't use safety plans in isolation. It's really important we have conversations around other interventions and signposting to other organisations for support if it's appropriate. Secondly, the point here about wider conversations about mental health and suicide in order to break down the stigma, so that people feel comfortable and confident to discuss it. And finally, I do want to highlight once again that you are all the professionals in your field, and you know the individuals you're working with. So as much as we can guide you, sometimes it is your call. I hope this has been really useful. I appreciate it's a different format, and face-to-face sessions we have had a lot more opportunity for wider conversations and discussions. So if you do have some underlying questions, please don't hesitate to get in contact and I'll help as best I can or signpost you to someone who can. That's my email there, and thanks again for listening.